my screen now. I hope that's working now. Is it working? Someone please confirm that it's working.
Yes, working.
Yeah.
Excellent. Very, very good. Very good. Good afternoon, everyone. Hello. I'm super excited to be here. Sorry about those technical difficulties, but we're through them and we're here. It's a pleasure to be kicking off today. And to be honest, I'm extremely impressed with the lineup that UCL Wilderness Society has organized. So well done to them once again. And I'm very humbled to be involved. So thank you once again. Think of me as a sort of warm-up act to get your aerospace medicine blood pumping for the rest of the incredible acts. So management of aviation, medical emergencies, and a few other things. We don't have much time, so let's get straight into it. Are we moving? I don't know if we are. Yes, we are. Excellent. Brilliant. So, case study one. So, pneumocephalus or not pneumocephalus. So you are on a aeromedical transfer from Berlin to London Gatwick. Okay, this is 2.5 hours journey time approximately, and you're taking a patient that has had a craniectomy, 2 weeks, and who is 2 weeks post-op, and who is deemed fit to fly by commercial airplane. So this is a level 1 ward patient who's on oxygen. Obviously, the past medical history is a traumatic subdural hemorrhage. You're traveling on an Airbus 319-100, and you're at 35,000 feet cruising altitude. And of course, the cabin pressure is about 7,000 feet, 8,000 feet. Now, on ascent, the patient experiences extreme retroorbital pain and a headache on their forehead. And starts having epistaxis, starts having a nosebleed. Observations are 120 heart rate, blood pressure 160 over 100, and a respiratory rate of 26. So clearly there's an issue going on. Now, I want to leave you with this picture. I want you to think about it, and we're going to come back to that. Okay, that's case study one. So, who am I? Who am I? Now, for those early on in their career, this slide is, I think, possibly the most important type of slide that you're going to be seeing today, considering the people that are going to be talking. Why do I say this? Not because it's about me at all, but because actually these people are so amazing. They've done so much amazing things, but it's more about what they've done beforehand to bring them to that point. Whenever I listen to talks, whenever I talk to inspirational people, I always think, what led them to that point. And I think if you evaluate that critically, then you can pick out what you want to do. And fortunately, we've come to the stage in this specialty and in this industry that actually there's a lot of people doing amazing things. So they've kind of paved the way for us. So if you could do that I think that would be really, really useful for you. And like everyone says in anesthetics, there's not one right way to do something. There's many right ways to do something, and it just depends, what works for you. So who am I? So I graduated from Peninsula Medical School in 2015. Normal medical degree, really enjoyed it. Didn't know too much about aerospace medicine at that point in time. But I always had a fondness of, space medicine and space. Just from media and films, really. I did my foundation training in Aberdeen and in Peninsula, so two quite rural places. There's quite a lot of opportunities there because of that, particularly pre-hospital stuff. And of course, there's some great aeromedical institutions in both ends of Britain. So that gave me quite a lot of opportunity again. I did clinical considerations of aeromedical travel That was a course in 2016. That's a week-long course, and that was pivotal in getting me started off again. I did a wilderness medicine course, World Extreme Medicine 2016. I then started working for International SOS, who are an international medical assistance company, and I was a coordinating doctor. So I did that for about a year alongside working in A&E. So I did that at the same time. Then after that, I wanted more experience. I wanted a stamp of my education in aviation medicine, and I wanted it to be official. So I did diploma in aviation medicine in King's College London. Really interesting and really something that you should think about if you're going to take this seriously. Then I became a Royal Aeronautical Society member, Aerospace Medicine Association member, went to the conferences, did a presentation at one of the conferences. I started working as a flight physician. And to be honest, my work as a flight physician, I've done that for the last 3-4 years. So that's been ongoing. I've kept that up throughout leaving foundation training. I've done over 100 missions commercially, fixed wing on different types of aircrafts, small aircrafts, jets, all over the place, intercontinentally. I did the space medicine physician conference, physician course, in last year, and of course, aerospace medicine podcast, which is something which is really exciting, I find, and something we need a lot more people involved in. So I'll leave that taking over in your minds. And right now, I'm currently a anesthetic trainee in London, and I do some pre-hospital stuff. And I also work at Heathrow in the COVID response team. So the focus points of today's talk include important fundamentals of aviation medicine, structure and function of the aeromedical industry. Is there a doctor on board? Commercial aviation and aeromedical retrieval medicine, things that you should know. And of course, we're going to have some aviation medical emergencies sprinkled in, some case studies to learn from, and of course, how to get involved, which is, of course, very, very important. There's a lot packed in, so we have to move quick to get through it if we're going to get through to questions. So this here is an awesome little diagram of what it means to do aviation medicine and how to understand aviation medicine. So it breaks it into 4 quadrants. If you have a look, the top 2 are states of physiology, so on the ground. So you have health and disease on the ground. Okay. When you're in medical school, the first 2 years is about learning physiology and about what it means to be in a state of health. And you need to understand what it means to be in a state of health before you can understand disease, because of course that is a deviation of health into a state of disease. And it's the same thing with aviation aerospace medicine, perhaps more exaggerated. Now, aviation space medicine, at the core, it's an occupational medicine sort of specialty, dealing with people who are working in that environment and making sure they can do their job. But of course, out of that is born this thing called aeromedical retrieval and transfer, which I'm going to be talking about. And the 2 points, again, 3 points, which are important, are disease states and how the body is changed by disease states. But on top of that, how aviation and the aerospace environment changes disease states. Okay, and this is in 2 forms: fitness to fly and aeromedical evacuation. Fundamentals of aviation medicine. Now, this is important. This is hugely important. Does anyone know who the person is in that picture? Write it in the comments or say it out loud. You should know who that is. Very, very important, because it comes up again and again. Before we carry on, I want someone to tell me who that is, if possible. Be quick, be quick, be quick, please. Someone tell me who that is. 5, 4, 3, 2, 1. Who's going to get it? Nope. Okay. I didn't see any comments come up. No one said anything. I don't know. But that is.
People said Boyle. One person said Lee Won Hook. One person said Newton.
Okay, brilliant. Boyle, yes, it's Boyle. Boyle. He comes up again and again and again and again and again. So it's good to know his face. because I'm not the only person that's going to ask you about him. Now, these are the important 8 factors of the aviation aerospace environment. Number 1, in order of importance, okay, the hyperbaric environment. Then you have humidity. Things are a lot drier up there, and that affects physiology. Then you have acceleration, deceleration forces, and vibration, noise, temperature, which is important to us in aeromedical retrieval and transfer, human factors, and of course, radiation. All those very, very important. Changes to physiology. Now, this should be just revision for you if you're here, because I assume you're interested and you know a fair bit about aviation. But if not, if this is new, this is very, very important. Okay, so in the aviation environment compared to on the ground, we're up at about 35,000 feet. Now, when we go up, according to Boyle's law, pressure is reduced. And this very simple diagram shows this. So at the top, you can see there is more oxygen packed in that space. Let me write that down there, laser pointer. Good. So you can see more oxygen, more molecules packed into that space. Okay, that's sea level. Okay, 8,000 feet. That is what aircrafts are pressurized to. We have a little bit more spread out with this reduced pressure, 118 millimeters of mercury. And of course, at 16,000 feet, so when airplanes fly higher, it could be a fighter jet, which are pressurized to 16,000 feet, and they have oxygen systems to help them breathe because of that. Oxygen is really spread out, okay? And this is according to Boyle's law. Very important. I used to sometimes think that, it's more important just to understand the wider concepts when it comes to pressure. But actually, this is one thing that it's worth spending time understanding in great depth. It's very, very important on a mathematical, technical level, because it makes everything else a lot easier. Okay, very important. Then we have, does anyone know what this is? Does anyone, can anyone shout out what this is? This is Virchow's Triad, okay? Now, Virchow Triad is another very important concept to understand when it comes to aeromedical retrieval and transfer, because we're looking at this disease state that the body might be in, and aviation is affecting it. Now, what's important here is that respiration needs to happen in all the cells of the body. Now, for respiration to happen, you need blood to deliver the nutrients, the oxygen to the cells for the Krebs cycle to produce ATP and for the cells to function. Now, Virchow's Triad is disrupted. And how is it disrupted? Okay. If we go back to those 8 concepts and 8 changes of the aviation environment, we have humidity, and we have lack of pressure. So it's going to be drier up there. This causes dehydration, which is on the hypercoagulability side of things. And of course, you have circulatory stasis, immobility when you're in an aircraft. So therefore, you have a higher chance of thrombosis. And this is something very, very important to us. Thrombosis can happen anywhere. And of course, we have acceleration and deceleration. And even though in commercial aircraft, in smaller aircraft, fixed wing aircraft, even in helicopters, we don't have, severe acceleration, deceleration as we do in, fast jets. It is still important when we come to disease states, because the body is not working properly. We don't have the compensatory mechanisms to keep us in homeostasis. So these are the 3 things to understand which are important, okay? The Boyle's law, Virchow's Triad, and fluid shift. Fluid shift. Here we go. The structure of the aeromedical industry. Structure of the aeromedical industry. Now, this is something which is, I'd say, poorly understood. However, it's again vital to understand And to zoom out, one part is, of course, dealing with the technical aspect of medicine, dealing with sick patients, clinical medicine. But zoom out a little bit. This is an industry. This is a business. Money goes through, money comes out. This is an economy, and people need to be paid. So I think it's important to understand that. Who are the stakeholders? Stakeholders, of course, travelers. The people who are getting ill, people who are going to and from, the travelers, the businesses, the medical tourists, people on holiday. Then we have medical insurance, we have assistance companies, which I'm going to get into, and we have international hospitals who are treating patients. Of course, we have airlines, we have aviation technology, the scientists, the engineers who are providing this technology for us so that we can fly higher and we can fly faster. So all these people working together and making this wheel go around of the aeromedical industry. And of course, as you know, throughout the COVID pandemic, this has been destroyed. It's been absolutely destroyed, but it's coming back, it's coming back. And of course, we have different types of retrieval. And we have the coordination of retrieval and medical case coordination. Types of aeromedical transport. All aeromedical transport was not made the same. Classically, people think of HEMS. Helicopters. And that's on one end of the spectrum. And of course, we have the other end of the spectrum, which includes commercial repatriation and transfer and evacuation. Evacuation can happen on both sides of the spectrum. Evacuation being taking patients who are severely unwell and need critical care in a aeromedical environment. It can happen in a helicopter, it can happen in a commercial aircraft. But let's start primary. So primary aeromedical transport is moving a patient from a rural or urban location to, of course, to a hospital, and that involves pre-hospital care. Okay, that's the first place you find them, out of hospital. Okay, then we have secondary. So secondary is transfer of a patient from a hospital with limited resources to a hospital with more resources. Okay, fairly basic resources, but at least you have a level of primary care, so you can do advanced life support, or at least keep the patient alive. Then we have tertiary, and this is taking a patient from a healthcare facility, again to a hospital, to another healthcare facility which can provide definitive care. So places that have specialist input, specialist surgeons, thrombolectomies, specialist radiology services. Then of course we have quaternary. And quaternary is usually repatriation of patients for further healthcare or when they're going home. Okay. Now I focused on mainly secondary, tertiary, and quaternary. That's what I do. I've not done HEMS before. Again, we're zoomed out at this moment. Retrieval coordination and logistics. Now, this is very important and really is the backbone of the industry. When you have a physician, a nurse, or a paramedic with the patient in the airplane, taking off and landing, a lot of work has gone into that. A lot of medical knowledge and a lot of efficient medical decision making is needed for that to happen efficiently, and a lot of money is going around as well to make that happen. Fortunately, it's very expensive business and industry. Now, I did this for a year, like I said, and how that would work was we would get calls from all over the world with patients who might need aeromedical movement, and we would coordinate it. So classically, a doctor or nurse would open a case once they have a call, once they have a occurrence of someone who needs to move for perhaps an evacuation or for a surgery or whatever it might be, and then we start taking history. We take clinical details. We find out the location where they're in and the resources that they have there, and then we start coordinating with other places where they might need to go to get the care that they need. And it's not always as simple as they need to go home. Sometimes that medical condition might need a faster, more efficient intervention. Of course, so there needs to be an understanding of geographical location and geographical centers of medical excellence. So a lot of decisions which needs to be made, and of course the crew needs to be adequate and appropriate for that for that movement. You can have a paramedic, you can have a nurse, you can have a doctor, you can have a GP, you can have a specialist, intensive care. You know, if the patient might need ECMO, and usually when you need very specialist services, again, you know, the availability of these specialist services is going to be quite scarce. So, which begs the question: do you really need those specialist services and skills? Because that might increase the length of stay in certain areas, which the patient might not have time for that. And this really is a case of life or death when it comes to it, because some places are just unsafe for patients to be in, and decision making needs to be very well thought out. Okay. Now, an example, a really poignant example is, let's say, a patient needs to move from somewhere in rural Africa to, let's say, Paris, or let's say somewhere center of medical excellence, Johannesburg, South Africa. The correct sort of aircraft needs to be picked, and this goes down to the amount of refueling stops that this aircraft might need to have. Say a Learjet versus a Challenger. So we can see a Learjet at the top there and a Challenger at the bottom there. Learjet will need to stop multiple times. A Challenger may not, has a wider range. And medical knowledge is important here, because the more stops and starts you have, exposes the patient to more acceleration and deceleration forces. And you need to have an understanding of the physiology of the patient. Say they have heart failure, say they have a nephrotic syndrome, or a kidney syndrome, or a disease, which means that they have ineffective pumping of the blood and the fluid around the body, means that they're going to have blood pooling in their feet when they take off. And that happening multiple times is going to make it harder to keep the patient alive through the whole journey. So that knowledge is very, very important. Like I said, a lot goes into it. So and I don't think this type of decision making is talked about enough. Common medical emergencies on board. Yes, that's me doing intubation or RSI on a King Air Beechcraft. We shall revisit that a bit later on. Now, common and medical emergencies on board. Now, 2013, New England Journal of Medicine said that in-flight medical emergencies happen 1 in every 604 flights. Okay, that doesn't sound very often, but it is, because there's a lot of flights every day. Okay, so if you fly often enough, you will be called. You will hear that bell go off. Is there any medical professionals on board? So I hope I can help you prepare for that. Okay. 11 out of 12 flights actually have a doctor on board. So despite the fear that many travelers have, that if you fall ill on board, that's it, it's all doom and gloom. No, it's actually probably one of the safest places to have a medical emergency. Most of the time, 30% is going to be a syncope. It's going to be someone having a faint. It's going to be someone being lightheaded. It's going to be vasovagals. Okay. 15% of the time, again, it's going to be GI upsets. Often people are in unknown places with new diets, and again, the aviation environment causes problems with the gastrointestinal tract, with expansion of air. So nausea, vomiting, again, diarrhea. Respiratory is 10%, shortness of breath, cough, asthma, cardiovascular symptoms, chest pain, arrhythmias, and seizures. What's quite interesting is seizures. One of the most common places to have seizures are in airports and on planes. Why? Well, not what you think. actually. So the theories about why this happens is actually, rather than the aviation environment having a significant effect on it, it's more actually that the people who have these seizures have higher levels of stress and reduced amounts of sleep, which are huge factors when it comes to seizures. I just thought that was interesting. Of course, 5% are strokes. It's all acute medicine, all acute medicine. Now, what do you do for these medical presentations, medical emergencies? It's A to E. It's A to E assessments. That's all it is. If you know how to deal with these presentations on the ground in acute medicine in the emergency room, then you do know how to deal with them on the plane. But what do you do differently on a plane? What value can I add? Number one, you get the oxygen on quicker. You get oxygen on the patient more quickly. They have oxygen on aircrafts to varying degrees. But usually they have medical oxygen, which can deliver up to 6 liters. Unfortunately, most of the time, they don't have more than 6 liters. But you put the oxygen on faster, and that's going to buy you time. Okay. You think through the eventualities that can happen. You make an escalation plan. Think, okay, what can I do? If this gets worse, what will I do? You make space. This is very important. Move them to first class, or ask the flight attendants to make a bed on the floor where they can lay down. Get IV access early. There's nothing worse than you're trying to get IV access in a patient who's deteriorating in front of you on a plane, which may have turbulence. Do it in a relaxed environment. Get it in early. Okay. Communicate with the pilot, MedAire, which we're going to talk about, and other doctors and flight attendants faster. And often there's, like I said, there's 11. Out of 12 flights, there's going to be 11 of them with doctors on, and normally there's more than one doctor. So talk to other doctors, see what skills you have there, manage your personnel so you can lead effectively, or of course be part of the team, and add to the medical acumen there. Use onboard Wi-Fi. If there's someone in front of you and you can't immediately remember what you need to do, use your phone. They normally have Wi-Fi. Now, infection. Infection is a hot topic now with COVID, being that people are worried about if someone's got a fever or someone's got a cough. Now, what you should do in this situation, and what we do when we get calls at Heathrow, is we quarantine these patients or these passengers in the airplane. The way to do that is you remove the other passengers from them. So it should be at least 2 rows in front and 2 rows behind. So if you say 2 rows in the front, 2 rows behind, they will listen to you. Or so in some instances, if they're well enough, they would need to be quarantined in the toilet, and we've actually done this before. Of course, they are monitored and they need to be well enough to do this. But at the end of the day, you have it in a closed environment and potentially a very infectious disease which can be passed on, which can pose a public health risk. Okay, and of course, PPE. So those are the immediate things which you can do. And I want to take you back to a situation that I had where I was going to Atlanta for a job to take a sick patient, and we had a call for a doctor on a plane. So I was actually just sleeping. I was taking it easy, and I thought, okay. So I went to go and see the patient. And I thought, okay, I guess this is my bag. This is what I do. So I'm gonna do a good job. But there was already a doctor there dealing with the patient. And I asked, is everything under control? Can I help? And they said, yep. The doctor said, yep, everything's under control. It's fine. And I just asked, okay, so what is it? What's the situation? And the doctor proceeded to say, everything's fine. You don't need to worry. You can go back to your seat. I thought, well, okay. Yeah, I just wanted to help. I thought, I'm sure it's fine. He's got it under control. But then I asked one of the flight attendants. I said, you know, just make sure you check the blood sugar of the patient, because often that's forgotten. You know, ATE, never forget glucose. At the end of the flight, I walked past where the passenger was, and I saw 3 empty packets of glucogel. So it goes to show, never ever forget glucose. You know, it's always be aware of, you know, who you're working with, and you know what's the situation. And when you volunteer to help, you know you are vulnerable, because you know that's your liability. You know, you have a responsibility at that point in time. So you know it is a responsibility. So you should think about those things when you agree to help. Now I'm going to put you in the driver's seat. Now you are on a long haul flight from France to Bangkok. Okay. You enjoy 2 glasses of wine, and you're watching Spider-Man: Far From Home. There's a call for a medical professional with a serious medical emergency on board. What do you do? So you're inebriated, you've had alcohol, you're drunk, you're lightweight. And what do you do? Please switch on your microphones, and I want to hear some responses. What do you do? What do you think you should do? I can see the answers in the chat. Tell the flight attendant. Okay, mention the 2 glasses. Can someone put their microphone on and speak if possible? Anyone? You're drunk? Don't you're drunk? Don't treat. We can't. Okay. Okay, fine. You can't put on the mics. No problem. Okay. Someone said finish the movie. Okay. Okay. So now this is where it gets interesting. This is where it gets really, really interesting. I mean, you would think that yeah, of course, you're drunk. Don't help. But let's think about this. What does the law say? What does the law say? So French, German, and Australian law says, whosoever does not render assistance during an accident, although required, shall be punished with imprisonment or fined. Whether you're drunk or not, it doesn't talk about whether you're drunk or not. It doesn't talk about whether you're tired or not. If you're a doctor, if you're a healthcare professional, if you don't help and the patient comes to harm, the passenger comes to harm, then you shall be punished. Okay, it makes it very clear. Okay, there's no ifs and there's no buts. Okay. These may apply if you're flying over a country, if you're flying in that airspace, or if you've flown from that country. Okay. So what do you do? Number one, find out what the rules are. Find out where you're flying over, and of course, you go and look. You go and see what's going on. If you have it in you, you know, if you're not totally inebriated, you go and see. There's nothing wrong with going to see what's happening. Okay, you need to have your medical ID on you. So you know, a way around that would obviously be not taking your medical ID with you. But I think it probably makes sense to have it on you just in case. Okay, so you go and have a look, see what's happening. It may be helpful to actually wait a few rounds of them asking for medical assistance, because someone may go before you, someone may go in front of you. So you can actually take a back seat. Okay, but it's always good to have a look. It's always good to have a look, and you know, this depends on, you know, everyone, you know, personally. But for me, I would feel some type of way. I don't think I would be comfortable with sitting down and you know, no matter any state that I was in, I couldn't just sit down. I would have to look. I would have to just see what's going on. You don't know what's happening. Okay. Now there's the Good Samaritan law, which covers liability. So while in flight on airplanes, the American Aviation Association actually protects physicians and other healthcare professionals. Okay. But you know, that's what the law says, and it's difficult, and it is really difficult. Okay. Now we're gonna go into more detail about what you can actually do, but this is a difficult situation. Okay, but you can't do any harm by having a look. Okay. Now, don't want to see the patient immediately if you're not inebriated, or if you're confident. If you're not confident, like I said, wait until the second or third call. Someone may go ahead of you. Now, MedAire is a ground-based medical liaison service. If you're if you have enough strength in you to have a conversation on the phone, which you should be able to do, you know, then you can actually talk to doctors on the ground who are going to give you advice, and you can these doctors can activate and give advice to other people as well. So if you can't chat to them, you tell someone else to chat to them, and they're going to do the job for you. Okay, so MedAire is a ground-based service where you do that. There's doctors based in Arizona, emergency medicine consultants who are going to help you. Again, if you're confident to deal with it, and if you're not inebriated, if you've not had any substances, then you get your medical kit back, okay, and you get the medical oxygen. That's the first thing you do. There is something called the Dr Onboard program, which Lufthansa run, whereby it's a recognized program for doctors to be part of. So you know they have a list of doctors who may be on board who can help, which is really useful actually. So you have a discussion with them and you talk what can be done. So I definitely encourage you to sign up to that if you can. You need to do a little application form online. And the flight attendants are first aid trained, and it's their job. Okay, they're first aid trained, so you can tell them what to do. You don't actually need to touch the patient. You can tell the flight attendants what to do. Okay, and you talk to the captain. Okay, so it's all about making a good AE assessment. Okay, MedAire isn't on board all airlines, but ones that are the better ones: Emirates, American Airlines, Turkish Airlines, again. Once you have a plan, once you've done your ATE assessment, talk to the captain and explain the plan. Let them know exactly what is going on, because they may offer some really great alternatives, like diverting, or flying in a different course if it's going to be turbulent. Okay. So this is MedAire. Part of the MedAire package is having a Tempest Pro. Tempest Pro is state-of-the-art technology, which allows telemetry. So the observations being sent to the ground-based service, to the consultants on the ground to give you help. As defib, there's end-tidal CO2, and there's a camera in it. There's a speaker. There's an ultrasound function. You can do a vascular exam, invasive blood pressure monitoring. You could do everything you can do in an intensive care with this piece of kit. This is very it's an amazing piece of kit. So you could do a lot if you have the skills. If you have the skills to do so, like I said, if you have the skills on the ground, then you should have the skills in the air. And you have a whole lot of doctors who are ready to help you in the air. Also, if you have the MedAire service. Now, physicians' medical kit. This is a hot topic because most people, even a lot of flight attendants, don't know about this. You need a special code to open it. You need to talk to the pilot. It almost feels like you're opening Pandora's box when you open this, because this is a full medical kit. There's control drugs in here. There's intubation kit in here. You can do a lot with this kit. The only thing it doesn't have is fresh blood. You can do a lot with this. Now, I've had to open it once for a patient who was is deteriorating. Sorry, someone said the video is off. Don't worry. Is that to me? Can you still see? Do we have technical
No,
difficulties?
that was to someone else.
No problem. No problem. Good, good, good. Now, the question is, should you get this medical kit out, because it is a very, very big deal when you get this out, because like I said, you need a special code, you need to talk to the pilot. But if in doubt, get it out. This is why you need your medical ID. You've got a patient in front of you. You need to deal with it. You need drugs. You need to have your medical ID. It would be irresponsible for a pilot to let any doctor, however senior they say they are, to open this, because this has got controlled drugs. It's got everything. It's got all the big boy drugs that you want to save patients' lives with. Okay, so it's there. Medical kit bag, physician's kit bag. Case study 2. And this is a true story. 64-year-old patient, cancer patient, with a chest drain in situ, with a transudative effusion, drained over 4 liters over the past week. So this is quite serious, using a lot of fluid. A Heimlich valve, flutter valve in the chest drain. We booked a business class seat for this patient. However, due to an issue with oxygen placement and configuration of the aircraft, we need to sit in economy. I ask if the patient is happy to do so, and I have a liaison with my medical personnel on the ground, medical director, and they say if patient's happy to do so, because obviously a business class ticket has been paid for and that's what they deserve, and we're happy to do so, to fly on economy, because they just want to get home. Okay. Now, number one, there's a high. Okay, we have a question about medical students. We're gonna talk about that soon. So that's a really good question. Okay. Now, number one, there's a hydration issue. Everything is drier up there. Number two, there's a issue with the patient. The patient is upset, and he's uncooperative with the oxygen which we have on him. He's having 2 liters of oxygen, and he has a leaking chest drain. So fluid is actually flowing around the chest drain. So this is an issue. Okay, I'm encouraging the patient to drink water, but he's actually not. His oxygen saturations reduced to 80% when he takes his oxygen off. So this is an issue. He finishes eating, and I ask him, how do you feel? He tells me his birthday. I say, do you feel okay? And he says, thank you very much. Can I have another one? Patient's confused. He looks gray, and he looks pale. And there's that look that patients have that something's going down. I tell the flight attendant passing by, I think we have a situation here. Please can you stand by while I treat the patient who's with me. I increase the oxygen concentrator to 4 liters instead of 2. That's as high as it can go. I ask for the medical oxygen. I say, please can I have the medical kit bag, and I do a set of observations. I don't really need to do the observations to find out that he's sick, really. I can see he's sick. I just want to find out what's going on. Heart rate 102, blood pressure 85 of 60, respiratory rate 18, aporexial 93% oxygen sats on 4 liters. He's sick and he looks great. I say, please can you prepare a makeshift bed in the galley? Remember, he's in a economy seat at this point. And this brings me to my next point. Business class is more than about comfort. Now, when someone's in the economy, they're exposed to a lot more stresses of flight than someone in business class. So it's healthier. It's better for health for someone to be in business class. They're more at risk of, if we look at Virchow's Triad, they're more at risk of clots. They're going to be more stressed. They can't relax. They're more at risk, of being dehydrated. The air in the cabin is more stuffy. They're more at risk of infections. business class, you can see here, it says it all. So actually, business class is more than about comfort. I'm getting conscious of time now. Call me up if I need to hurry up. Talk to me about time, because I don't want to cause any problems here. Now, 5 minutes. Okay. This is the PTC. This is a state-of-the-art commercial transport system run by Lufthansa, which gives us the capability of running a intensive care unit on a commercial airplane. This is amazing, and they actually give you an intensive care nurse to work alongside you. It has everything that an intensive care would have, and it saves a lot of money, and there's less issues with pressurization, less issues with acceleration, deceleration, because of course you're traveling long haul, and there's less noise, and of course it's less dry. Aviation medtech. This is another case study I want to tell you about. We have a patient in northern Italy. We are flying a Lear 45, 35,000 feet, day 11 post-abdominal surgery. It's supposed to be level 1. Patient's supposed to be very stable. It's a tarmac transfer. We are going to transfer the patient on the tarmac. So I'm going to do my fit to fly assessment on the tarmac. And it's 40 degrees hot. It takes 2 to 3 hours for the patient actually to get to me. It's a long journey, and there's not a lot in between. So it actually takes another, it's going to take another 2 hours for them to get to a hospital if I say the patient is not fit to fly. Okay, so either we fly and it takes 2 hours to get to where we're going, or I say the patient cannot fly and it takes 2 hours for them to get to a hospital. So, and that hospital might not be able to deal with what they have. Fit to fly assessment, very, very important. Paramedic to doctor handover. The patient looks sick in front of me. They're not supposed to be sick, but they're sick. The patient was supposed to be stable. Okay, the patient possibly looks septic. Now, the decision which I need to make using my clinical reasoning is this patient septic? May they deteriorate, or are they just dehydrated? Like I said, it's 40 degrees. They've been in the ambulance with just a driver for 2 to 3 hours. We make a decision to fly this patient with a sea-level cabin pressure and to give sepsis 6 treatment in the airplane. Less fluids, oxygen, antibiotics, and antiemetics. Now, the key thing that we would do in a hospital that we needed to do here is to do a VBG, which is going to tell us a lot more about the bloods. And this is an amazing piece of kit here called the iStat, which we had and which we used, and that told us the information that we needed to know to tell us if the patient was septic or not. So this clinical reasoning, and of course tech. Something which is really advancing and something to be excited about. We can do 10-minute troponins with this. We can look at renal function, and yeah, we can do that in the air. That's pretty exciting. Okay, diagnostics in the air. To tell you about this once again, this is a simulation. This is not real. No one should be, if someone's intubating in an airplane, something's gone seriously wrong, particularly on an air ambulance journey, because it's all about prior planning prevents poor performance. And if someone does need to be intubated or RSI, they should do it before you actually fly. Again, the huge point that I'm trying to get across here is actually the work is done in the planning. The work is done in the preparation. Prior planning prevents poor performance, and that's the key skill of doctors who do this. They do all the planning, all the performance beforehand, so everything is smooth. Okay, there we are. I probably don't have enough time to tell you about this, but I was going to tell you about a decompression that I had. I was in the airplane. I was then going to talk about time of useful consciousness, which is a big concept to understand. And it's not just about the safety of the patient, it's about the safety of everyone in the plane. And knowing what to do in this decompression incident is very, very important. And that's why simulation training is very, very important. Of course, we have simulations of fires on board. We have simulations of patients kicking off on board, critical incidents, and of course the human factors training. I'm gonna skip. Unfortunately, I'm sorry I didn't have enough time. But four things which are very, very important, which I think you should do is number one, have a look at NGAM, Next Generation Aerospace Medicine. Have a look at Aerospace Medicine podcast. Contact us. We're looking for next generation of people to help us continue that. If you're keen, please join in. Do the Aerospace Medicine online course. That's 1,300. It's going to be money well spent. Do the CCAT course with Dr. Terry Martin. And anesthetic training is going to be great if you're interested in this. The work is done. Those are the four things that you should do following this if you're keen. We've done all the work for you. Just do those things. Again, conscious of time. Thank you very much for listening.